Immunosuppressants and anesthesia, sir.
Okay.
Introduction. Immunosuppressants are generally the drugs that suppresses or modulates the immune system. They are mainly used to prevent graft rejection after organ transplant and to treat autoimmune diseases like rheumatoid arthritis, lupus, myasthenia gravis, inflammatory bowel disease, etc. As we anesthesiologists frequently encounter these patients for elective and emergency surgeries. So in these patients, what are the challenges we usually face? Or the altered drug metabolism in the patients, risk of infection, delayed wound healing, drug interactions, renal, hepatic, and cardiovascular side effects we will face. So, what are the common immunosuppressant drugs we encounter and their mechanism? The first commonly encountered drug is corticosteroids, mainly the prednisolone and methylprednisolone. It's a broad anti-inflammatory and has immunosuppressive effects. This major side effects of the drugs are like hyperglycemia, hypertension, infection, and adrenal suppression. And the second class we encounter is calcineurin inhibitors. Examples are cyclosporin and tacrolimus. The mechanism of action of these drugs in this class of drug inhibits T cell activation and by blocking the calcineurin and interleukin 2 synthesis. Major side effect of these drugs are nephrotoxicity, hypertension, tremors, and seizures. The third group of drugs are anti-metabolites like azathioprine, MMF. In this group has a mechanism of action which inhibits the purine synthesis and it suppresses the lymphocyte production. Major side effects are bone marrow suppression and hepatotoxicity. The fourth group of drugs are mTOR inhibitors, mainly sacrolimus and everolimus, which inhibits T cell proliferation via mTOR pathway. It has poor wound side effects of these drugs are poor wound healing, hyperlipidemia, and thrombocytopenia. The fifth group of drugs are biological agents like basilizumab, rituximab, which are monoclonal antibiotics, targets the specific immune cells or cytokines. In this has infection, hypersensitivity, and infusion reactions. So, what are the perioperative concerns in these patients who are on immunosuppressants? So, we have to perioperative considerations in these patients. We have to get detailed medical history and evaluation. Indication for why the patient is indicated for this immunosuppressants, like for transplant, or the patient has autoimmune disorders. So how long the duration the patient is taking and what dosage, when was the last time the patient has taken this dosages, and associated comorbidities like hypertension, diabetes, renal or hepatic impairment. Investigations, normally we ask for CBC, renal liver function test, electrolytes, blood sugar. If possible, if the patient is on tacrolimus, we generally ask for tacrolimus levels. And we have to ask the patient for if the patient has any minor history, infection history, or the patient had a previous history of sepsis, if the patient had any IV or IV cannula lines, if the patient is on any prophylactic antibiotics. Drug interaction. Many of our immunosuppressant drugs are metabolized by CP4, CYP450 system. So this interactions with anesthetic drugs, anticonvulsants, macrolides, and azoles. And the patient is on drugs, the patient usually avoid NSAIDs. And the patient has history of steroid therapy. It's a main one we generally ask. The patient is on prednisolone or methylprednisolone. Because this chronic steroid use, which usually leads to HPA axis suppression. So we must give stress dose steroids during surgery to prevent adrenal crisis. We should continue this immunosuppressions. Usually we usually generally continue these drugs to prevent the rejection unless it is contraindicated. So what are the intraoperative considerations in this patients? First, the cyclosporin. The cyclosporin normally potentiates the non-depolarizing muscle relaxants. So we have to generally use neuromuscular monitoring and it may cause hypertension, nephrotoxicity, and seizures. This tacrolimus is it's also similar to cyclosporine, may causes arrhythmia, nephrotoxicity, and neurotoxicity. MMF, which causes GA upset. Sirolimus, which has a poor wound healing capacity, we generally avoid early elective surgery after initiation. Corticosteroids need preoperative and post intraoperative steroid supplements. We should also watch out for hyperglycemia and delayed wound healing. So, what are the anesthesia management point of view in the patient we are using who are using immunosuppression drug? The choice of generalized anesthesia, we can use either G or regional. The regional is generally preferred because it is a asepsis, but airway may be affected by long-term steroid use like Cushing factors and obesity. Hemodynamic monitoring is especially the patient is hypertensive. Renal protection, avoid nephrotoxic drugs during surgery, maintain good adequate hydration, always watch out for good urine output, neuromuscular blockade, prolonged effects with calcineurin inhibitors. So use peripheral nerve stimulator to guide for the relaxation. Post-operative management, resume immunosuppression drugs as early as possible. Infection control should be how to prescribe adequate antibiotics for this patient. There will be delayed wound healing in this patient. For the post-operative pain management, avoid NSAIDs, prefer paracetamol or opioids or regional blockades. And steroid supplements in the patients normally in minor surgeries like hernia repair, cataract, continue the normal daily dose. In moderate surgery like cholecystectomy and hysterectomy, add give normal dose, continue the normal dosage with hydrocortisone 50 mg IV before induction and 25 mg every 8th hourly for 24 hours. In major abdominal cases, hydrocort 100 mg IV before induction and 50 mg IV every 6th hourly for 48 hours. That's all, sir. Thank you, sir.
So you have concentrated mainly on immunosuppressants used for graft survival and
Yes, sir. And the steroids.
autoimmune disorders.
Yes, sir.
Do anti-cancerous drugs have some immunosuppressant effect?
Yes, sir. Like doxorubicin, that also causes cardiac depression drugs.
So
The,
patients who are taking anti-cancer therapy, the form of chemotherapy, they are also prone for immunosuppression. So they
yes, sir.
also have to be included in the answer when they say, though they are not primarily called as immunosuppression drugs, their side effect is immunosuppression because in their mechanism of action to kill the cancer cells, they also suppress the normal cells, isn't it?
Yes, sir.
So that also has to be included. And another point you have to add in your answer is, what is the immunosuppressive effect of the anesthetic agents we routinely use? Okay? So, which one suppresses immune system in our body more, whether it is GA or regional?
GA, sir.
Which technique of anesthesia, whether it is GA or regional, which one suppresses the immune system more, making the patient capable of
General
picking
anesthesia,
up
sir.
an infection or something?
General anesthesia, sir.
General anesthesia. Among the general anesthesia, which one causes more immunosuppression? Intravenous or inhalational?
Inhalation, sir.
Inhalational agents cause more suppression. Okay, so that also has to be included in the answer. So
Yes,
there
sir.
are 4 categories which have to be classified. One is the regular immunosuppression drugs given for organ transplant rejection. The second is the, as you said, autoimmune conditions where immunosuppression or immunomodulators are used. Third is anti-cancerous drugs which have immunosuppressive effect on the body. Fourth is
Okay.
the regular anesthetic drugs used in even normal patients with immunosuppression can happen. Okay? So if you
Okay.
when you add all these things, then the answer will be complete. Otherwise, what you have given is 75% correct answer. But another 25% you have to add these things also to your answer, and I'll just show you how that can be